When you need someone to talk to and you don't know what to do, call us 4400. When you're feeling all alone and they turn their back on you, call us 4400. Call us 4400. Call us 4400. Call us.
Hey everybody, good afternoon and welcome to the Kind Counseling Podcast. Today we have a special guest with us. Once again, our mission statement for Kind Counseling is to give hope to the hopeless through mental health, empowerment, and spiritual insight. And I just want to thank everybody for joining us today. And I'm really excited about our guest today. He's a good friend of the show, a good friend of the family, good friend of Kind Counseling. And he's here to dispel some myths and to give some clarity. As you guys know, we're trying to remove the stigma of mental health services in the Black and Caribbean community, right? African American, and Caribbean community. So we want to welcome Dr. Pierre Ardy. All right, Dr. Pierre Ardy. And he is he's currently the director of psychiatry at Housing Works. He's been in the field for over 20 years now. And, he's the main guy that I call when I got questions. So, I'm really excited to talk to him about some of the issues around psychiatry today. And he's also an author. He's also an author of a short story book called Life and Death and the Things in Between, which is available on Amazon if you guys are interested. So let's welcome Dr. Pierre Ardy. How you doing today, sir?
I'm okay. I'm doing great. Carmi, thank you very much for that very kind introduction. I sincerely appreciate it. And yeah, I've been in this field for over 20-something years, so I appreciate you giving me this opportunity to share some wisdom and some knowledge to the community, and I hope that by God's grace it will do some good. So again, thank you very much for that very kind introduction.
Kind, huh? All right, I got you.
From Kind Counseling.
Right, I got you. So, all right. So, one of the, and like I said, part of why I'm doing this is because there's a lot of misconceptions about psychiatry, right? And one of the biggest sources of confusion is most people don't understand the difference between a psychologist and a psychiatrist. So, if you could just briefly or just tell us a little bit about that. What's the difference?
Well, thank you for asking that question. It's a very common question. A lot of people do have a lot of misconceptions. Just let me start out by just saying how I commend you for doing this for the community, because mental health or psychiatric care, even psychological care, is something that within our community, and I'm talking about the Caribbean community, African American community, within communities of minorities, especially communities from culture outside of the United States, there are misconceptions about what psychiatric care is about, what wellness, mental health is about. So for you to come out and to provide this service to the community, I think is just wonderful. I have to go back to the words of this doctor, Dr. Brooke Chisholm.
Okay.
This guy, now he was the first Director General of the World Health Organization when things just had first started. And what he said was that there was no health without mental health. There's no true health without, no physical health without mental health.
Okay.
This basically means that everything is intertwined. We're talking about wholeness. And for wholeness, you need not only your physical health to be in good condition, but you also need your mental health to be as sharp as possible. So we'll just start out with that.
Okay.
Now, to tell the difference between a psychiatrist and a psychologist, well, I'm a medical doctor.
All right.
I've gone to medical school, and I, being a psychiatrist, I have the license to prescribe medications because I've had a body of training, classes that I've taken, having gone to medical school, and then having completed a residency program that provides me a certain a certification and licensure so that I can approach folks and treat them on a biological level.
Okay.
So I can certainly look at the brain and the mind. Of course, the mind is a concept, but I look at the brain as a biological construct that has neurotransmitters that at times are not working well, and because of that not working well, can result in someone feeling biologically depressed, clinically depressed, or anxious, or becoming even psychotic. And now what I mean by biological depression or clinical depression, I don't mean the kind of thing where you wake up Monday morning and you're about to go to work and it's like it's raining outside and you don't feel well, and Monday's not your day, and you just want to go back to bed, and throughout the day you're feeling sad, so that by Wednesday or Thursday you start to feel better.
Okay.
I'm not talking about that. By clinical depression, I mean something that compromises function. By not doing well mentally, I'm talking about things that compromise function.
Okay.
And that's where me, as a psychiatrist, somebody may refer such an individual to me. I'll assess them, and I'll see what's the best treatment. Now, the treatment may include psychological help from a therapist, from a psychologist. Nowadays, there are some psychologists who are able to prescribe medications. I don't think it's that way in New York, but I'm really not clear.
Okay.
But these are PhDs, doctors in psychology. They are not MDs, medical doctors. So their way of approaching things may be more from a psychological point of view, trying to understand the dynamics of interactions and how, let's say, past trauma can affect someone's present condition, and then they can figure out ways of addressing those things by speaking, by talking, by listening, by giving suggestions, by counseling. So it's just a way of treating someone wholly, but we have two ways. And sometimes those two ways can interject, and we work together for the wholeness of the individual. I hope that helps to answer the question or clarify things.
Right. Okay. So now when I have conversations with my clients and I say to them, listen, you're struggling here or you're struggling there, you seem depressed, or you're really, you're not functioning well in your everyday life, and I'm really concerned about you. I'm thinking about referring you to Dr. Artie. Right away, the reaction is, do you think I'm crazy? Like, and there's an immediate, like, visceral reaction to almost like, like, how dare you, or like, what's wrong with you? So if you can speak to that a little bit, why is it in the African-American and the Caribbean community, there's such a stigma about even being just referred to a psychiatrist?
Well, I don't think it's too difficult to understand that when you question someone's state of mind, people can get offended by that.
Okay.
And they have feelings about that.
All right.
Because no one wants to question their own state of mind, to consider the possibility that they're not, emotionally well or psychologically well. It reflects how one considers oneself. It's somewhat of I would call it a narcissistic injury, meaning that whatever or however you consider yourself, maybe you're not all that. So there are reasons why somebody would consider that. Nobody wants to be, called out as the weak link. Another thing is culture is also an influential thing. Whereas, for men, the machismo thing, no one, men generally would not like to be considered weak in any way. And so to say to someone that, hey, you're not all there, in a way, people can take that as an offense. What are you saying? Are you saying I'm weak? Are you saying I don't have it all? So culture has a lot to do with it, certainly in Latin culture and our own culture.
Okay.
How one considers oneself, how one looks at your own self and others, that has a lot to do with it. Another thing is religion or spirituality.
All right.
A lot of folks who are raised within religious circles may consider questioning their mindset not only an offense, an insult, but they may consider that they may translate your questioning their mindset as if you are insinuating that maybe they're not spiritually there.
Gotcha.
That maybe they're not all spiritually well wrapped up as a sign of spiritual weakness.
Gotcha.
And people don't want to consider themselves in that way. So I think that there are a lot of hurdles that we have to overcome before somebody can come to a place where they may very well say, hey, you know what? Maybe this situation is such that I do need some psychiatric care, and whatever that may be, or subject myself to a psychiatric assessment. But I guess the short answer to a possible long question is that there are many things that can hinder someone: culture, religion, individual mindset, even influence of friends can affect that. But it's interesting in that you have the predominant culture that actually takes psychiatry to a place where it's cherished. It's people pay for it. People get therapists for their children, and they like it. As I said, they pay for it, and if you're willing to pay for something, it's something that you cherish. So it's interesting that there are different views on the same topic depending on your background.
Okay, so now the other thing that I'm faced with is if I say, listen, I think you should go see my friend Dr. Artie. It's I don't want to be on medication, right? So every time someone is referred to you, do you put them on medication?
Okay, good question. The medication question has to come up. To answer, no.
All right.
It's an assessment that the psychiatrist does.
Right.
To see if this situation merits some kind of intervention that could possibly help. Now, prior to putting anyone on medication, we see how they do without the medication.
Right.
What is the extent of their suffering? If you tell me that the person is depressed, sad, doesn't want to go out, has not been able to go to work, hasn't been showering, doesn't brush their teeth, and this isn't just a day or two or a week or 2 weeks, but this is going on for, more than 2 weeks.
Right.
It's interfering with their life function. They're about to lose their job. And we have to intervene in some way. And so I don't push medications onto anyone, but I will make suggestions depending on the presentation. But it comes down to function. It also comes down to the length of time that the person has not been functioning well. But the first course of action is to do the appropriate assessment and see what the situation is. If it's a situation having to do with dynamics, if it's a situation having to do with, let's say, appropriate mourning, there's a loss, there's a breakup, there's someone died, then the person's not going to feel well, and you have to give them some space and some time to heal. Because depending on the trauma, we all need some space, we all need some time so that we can adjust to it. But it doesn't necessarily mean that you will need to be placed on medication. Okay. But there are specific illnesses that off the bat do well with medications. For example, if a person is psychotic, they have, let's say, what we call schizophrenia, or they have a mood disorder such as a bipolar.
Well, one second. Well, Pierre.
Can't sleep.
Well, Pierre, 1 second. What does psychotic mean, though, for the average person? What does psychotic mean?
Oh, okay. By psychotic or having a psychosis, I mean that someone has lost their footing in reality, meaning that their appreciation or their definition of reality or their sense of reality is not the same as yours and mine. Okay. If someone comes to me and they're telling me that they have a chip in their brain that was placed in there by Martians, and the Martians are monitoring them, right? That's not appropriate. Now, even with that person, I may not place them on medication if they're able to keep it on the wraps, they're able to function, they're able to do their work, and nobody will know about it unless they start asking them questions. Okay. Because it comes down to ability to function. It comes down to self-harm or not self-harm. It comes down to how they're engaging in the community. If they're harming anyone, if they're able to care for themselves. Okay. A lot of things will come into the equation so that we can make a decision having to do with medication. Okay. All right. So go ahead. Psychosis is a sense of loss of reality, where their sense of reality is not the same as yours. Okay. And I have read of people who are psychotic, but they've never taken medications because at some level they're able to function, and and so we let that be. But when it starts to interfere with your day to day,
right,
and other people's day to day, then we need to do something.
So now I've had many clients that have said to me, I went into a doctor's office, a psychiatrist's office, and they spoke to me for 10 minutes and they gave me medication. Are you the kind of doctor, or what do you think about doctors, I should say, that tend to work that way?
Well,
I know that's a tough
to
question.
say that I have heard of that.
Okay,
Yeah.
all right.
But yes, I have heard of that. Some people do that. I'm not one who would advocate that because I need to speak with the individual and see what's going on. I may, in a matter of 20 minutes, come to a conclusion in my mind of what I'd like to do or how I'd like to treat them. But then even approaching someone with that kind of decision is something that, depending on the individual, you have to, I think, do it with a certain sensitivity.
Okay.
I know that these days we're pressed for time because there are many people to treat. But still, I think that everyone merits treatment in such a way that makes them feel that you cherish them in some way, you appreciated their time, you value their time, and that you're going to give them something that they're going to take and place inside their body that may have potential side effects, and they have to know about that. So that's all part of the engagement. But yes, I have heard of that. And it really is unfortunate that some people are treated in that way.
Okay, so I'm glad you mentioned side effects because especially, I would say more so with my female clients, they tend to worry about things like weight gain, like sexual appetite. That's probably more so with men. But they're concerned about how are these things going to affect my everyday living, right? So can you speak a little bit about side effects and how do you address that if there are side effects?
Well, almost all medications have some side effect. It could be anything that from dry mouth to sleepiness, sedation, to maybe feeling activated, even sexual side effects. So the first thing is you just be upfront with the individual, and you can give them, at least I would give them, the most common side effects. Now, you can't go through every single side effect because it would take up too much time. And plus, once the medication is prescribed, they get what they call, I believe it's a prospectus of the medication that comes with the medication, and that gives you an education about it. In addition to that, nowadays, everybody is, has access to Google or whatever, whatever search engine that they would want to use in order to see all the potential side effects. And the pharmaceutical companies will clearly write almost every single potential side effect because they just want to, fear themselves and say, hey, we told them and the person took it on their own, so we're not responsible. So first thing is to discuss potential side effects. And then we weigh the risk and benefits. We always have to weigh risk and benefits. Now, among side effects, yes, women in general are concerned about weight, concerned about things such as, let's say, acne or things that would make them look less attractive. Hair loss is a concern.
All right.
So in general, you have to be sensitive to that. Men, what do you think is the major concern among men when they're taking medications?
I would think probably sexual, how it affects their sexual performance. No?
Exactly.
Oh, okay.
For men, that's it. A man is willing to lose his hair, but do not take the power of the erection. So that's the.
All right.
And we have to be mindful of that when we're prescribing medications, so that we can, so that the person may make an educated decision to either undergo a treatment or not. And then once the treatment begins, then we monitor those effects. Because it's not every medication that has sexual side effects. It's not every medication that causes big pain. We just have to make an educated choice in terms of what's the best thing for the individual, depending on their presentation. For example, if I have somebody who's a little chunky, overweight, and they have cholesterol issues, and they may very well have diabetes, I will try to avoid any medication that could potentially cause those things to be even worse.
Okay.
Or if somebody comes in and say, Doc, I want to gain a little weight, and I don't mind, being a little sedated because I'll take the medication at night. And there are medications that can help with that too.
Okay. All right. So, I would say another issue that tends to I would say predominantly one of the major issues that we deal with in my office is childhood trauma, right? So and we know that trauma, like affects obviously like the emotions and the ability to focus as well as relationships, right? So are you a big proponent of are you more so are you coming in on the side of you should deal with therapy for that, or you should do medication and therapy, or how do you weigh in on that?
I weigh in on that the same way I weigh in for all the other psychopathologies that may present themselves.
Okay.
I would approach them with therapy and see, how far can we go and address specific symptoms. Now, trauma is something that can actually change brain structure, especially childhood trauma.
Okay.
And so people get involved with therapy and try to address specific symptoms of trauma.
Right.
For example, nightmares,
right,
flashbacks, being hyper alert,
okay,
difficulty sleeping, having specific triggers. Now, you can go to a certain extent as far as the therapy, and that's all good. And somebody can, and what therapy does is it actually teaches the brain how to address specific memories.
Okay.
And also causes changes in brain function and structure.
Right.
Now, if the person is still after, let's say, whatever amount of time that the person would allow, if they're still having symptoms of, poor sleep, being hyper alert, being very anxious, having flashbacks, and it's not healthy for them, because the longer the brain stays in that type of state, the worse it can be for the individual. Then I would, intervene with some medication that maybe can help them get to sleep at night. And I have to say that sleep, we don't appreciate sleep as much as we should.
Okay.
If you can get a person who has a mood disorder, like a bipolar, just to sleep, that will help. A good night's sleep is rejuvenative. It rejuvenates, it regenerates, it recalibrates.
Right.
And so if the person is having difficulty sleeping, that just makes it, whatever it is, it makes it even worse. So maybe the person needs a medication to help them sleep, get a good night's sleep. And the next day, the symptoms, or the next week or so, the symptoms may be a little bit less.
Okay. Okay.
So there are medications that can intervene at certain levels to address specific symptoms.
Okay, all right. So I got a personal question for you. How does and I know you have you're born in Haiti, right?
Yeah. I was born in Haiti.
So how
precious country.
The precious country.
The precious country.
All right. So how does a guy from Haiti in the West Indies become a psychiatrist when black people in general tend to frown on it? How does that happen?
By the grace of God, and that's the truth. It happens by the grace of God. I didn't start out being a psychiatrist. I was involved in medicine.
Right.
I did a medical residency.
Okay.
And I became interested in substance abuse, addiction.
Okay.
And so I did a fellowship with that, but it turned out that a lot of those who were involved in addiction had mental illness.
Okay.
And so being younger, I decided, well, let me just do another residency and find out what mental illness is about. Because we may have a certain prejudice, or we do have a certain prejudice within our own culture having to do with mental illness. But I found even in the field of medicine, there are doctors who have prejudice pertaining to those who have mental illness. And so can you imagine how it is for someone coming into the kind of depressive illness, or another mood disorder like mania, or even psychosis, but they're unable to convey that well enough to the general population.
So, yeah, I mean, because I remember going to a barbecue once, and as guys sit down and they talk, and the first question is like, "So what do you do?" And I said, "I'm a therapist," and he's like, "What? You're a therapist? You serious?" Like he's like, you like being a therapist? like it was forced on me, So, just I mean, what's it like being for you as a psychiatrist as a black man? Like what's that process been like for you?
Well, to answer, what is it like for me? I love it. I love what I do. I think being a psychiatrist is like, just keeping your hand on the pulse of humanity. You know what people are going through, and they share that with you, and it's a privilege and it's an honor. You listen to them and you try to make a difference. To be able to pull someone from darkness to light, from psychosis to a clear-headed mindset, or from the bowels of depression to a place where they can see the light, or see life from black and white to color.
All right.
I think it's just an absolutely wonderful thing. It's not for everybody. Not everyone can do it. By God's grace, I'm able to do it. And so I think it's just an absolutely wonderful thing. Now, are there a lot of people of color in this field? Well, there aren't a whole lot of people of color in the field of medicine in general. So there is less in psychiatry, but things are changing and it's improving.
Okay.
But I do enjoy it. I think in the field of medicine, in general, we need diversity. We need people who look like us to treat people who look like us.
Okay, good. Okay. All right. Now, what would you say to the person who may be questioning whether I should go? They have some fears, they have some concerns. Like, what would you say to that person who, is debating whether they should actually go and see a psychiatrist or not? What would you say?
Well, nowadays, I think you can, whatever question the person may have, they can Google it. But if there's a need for it, something created that need. And so I would think that, what would it hurt to at least have a consultation? I think people have insurance books that list psychiatric care. They can call someone and just inquire in general. I think the first psychiatric assessment, it's relatively harmless. You're asked questions, then it's up to the person, because it's outpatient, and they have a right if they want to continue with care or not continue with care. Maybe the psychiatrist may say, hey, you don't need me, you need a psychologist, or you need a therapist, or you need such and such, but you don't need me. Here's my card, come back if you feel you need me. But the psychiatrist can also make referrals to a therapist, such as I've done that. I've used you as that.
Right.
Some people who not necessarily need medication, but they do need someone who's going to sit and listen appropriately and help them, make sense of their lives. Okay.
All right. So it's because I know the psychiatrists have the reputation as like the boogeyman, right? So we're trying to dispel that myth, right? So that's part of why we're doing this today. Now, go ahead. You want to say something?
Yeah, just a comment on that. How it is in America,
right?
The psychiatry and the boogeyman, but among us, people of color,
right?
There is an understandable mistrust, of the medical field. Because a lot of bad things, clearly have been done to all people, by medical folks. That's just the truth, from the Tuskegee experiment to other things. So I understand that concern when someone, submits themselves to medical care or psychiatric care. And nobody wants to be experimented on.
That's a good point. Actually, speaking of experimenting on, I mean, as a medical doctor, and we hear about the possible vaccine coming out for coronavirus. And right away, I think, based on what you just said, a lot of black people or people from the Caribbean are almost immediately saying, I'm not taking a vaccine. What are your thoughts about that?
Well, I hear that too, and I hear that at home. So that's understandable in light of the history of vaccines, and so in the United States and even around the world, and how people who are marginalized or traditionally been marginalized, how they've been treated. But I think that the vaccine now, it's being pushed at warp speed. Usually it takes several years to come up with a vaccine.
Right.
But with this one, in light of the death rates in the United States and around the world,
right.
People are just pushing it. Things are much more advanced than they were, a couple of years back. So I don't know how it's being made, but my understanding is that it's being pushed to be made. And there are people who do volunteer for these vaccines. For these experiments, you would say, prior to any product, any stable product to come out. People who submit themselves to this so that doctors can document side effects. So I'm not a manufacturer of vaccines, but one will come out when we don't know.
Okay.
But when it comes out, my understanding is that it would have gone through a series of tests to see what the potential side effects are and how efficacious it is. Now, everyone will make up their own mind when they'll take it.
Okay.
Some folks will take it from the get-go. Some folks will just wait and see what happens. But we've developed vaccines for the flu every year because of mutations. We take a flu shot. Those who are susceptible,
all right,
who are older and have predisposing illnesses, it is recommended that the flu shot is taken in order to guard against the flu because the flu kills also.
Right. Right.
And I have taken the flu shot.
Okay.
Several times.
Okay. I mean, me myself, I took it once and I got the only time I ever got the flu. so I've been taking it since about 20 years ago now.
Okay.
Yeah, I mean.
Well, I take.
Huh?
No, that's all right. I take it yearly, and but I work with. The thing is, I work with a whole bunch of folks. I work with patients, and so I don't. As you do, we work with patients from old age groups, and I just wouldn't want to become ill and then share it with someone else.
That's a good point.
Because I think that my body can take it. I'm fairly healthy, but I wouldn't want to have it and then go give it to some older person, or God forbid, give it to my father, who's 90 years old.
Wow.
And then he wouldn't be able to, to deal with the flu as I would be able to deal with it.
That's a good point. Okay. All right. I mentioned in the beginning, as we get close to wrapping up, as I mentioned in the beginning, you wrote a short story, right? And I wanted to give you a chance to talk a little bit about that. So tell us a little bit about your book, man.
Oh man, thanks. I appreciate that.
Yeah.
It's a book. I wrote the book, I think maybe 3 years ago. Well, it was published, I think, approximately 3 years ago.
All right.
But it's something that I've been writing for over 10 years. And the stories have to do with patients I've treated, my emotional and psychological experience of having treated those patients. It's also stories about my family.
Okay.
And, some emotional things that we've gone through. So it's about patients and family, and they're all true stories. They're nonfiction, but the style of the writing is such that I think it flows very well, and it's written from a first person perspective. Some are, and some are written from a third person perspective.
Okay.
And I think there are stories of hope. There are stories to encourage, because I think at the bottom line, all of us share the common thread of trauma. We've all been affected by life's hurts and pains in some way.
Okay.
And so I'm just putting myself out there in this book to just say what I've gone through and how I dealt with it by the grace of God. So,
okay.
It does come from a Christian perspective, but it's not preachy.
Okay. All right.
So and those who've read it, they've given great reviews. You can check it out on Amazon.
Okay.
And I thank you for giving me the opportunity just to talk about it.
Sure. Tell us the name of the book again.
Life and Death and the Things in Between.
Okay, Life and Death and Things in Between.
Yeah.
Okay.
And things in between. Right. Oh. It's my attempt to capture with words what somebody else may capture with a photograph. Just
okay.
Episodes in life that are very, very moving and that affected me. And it's also a way for me not to forget those significant events in my life. Because, as we get older, the events become a little bit more murky, not as accurate. You may need somebody else to say, hey, what happened then? I know I was there, but I can't remember it exactly. And this way I've written it down, And as I said, I've been writing these things for the past 10 years so that I can always remember.
Okay.
Yeah.
Okay. Let me ask you another question on the side over here. I know you've gone to many different countries, and then you've done medical clinics. And how are you received there when you go to other cultures and knowing that you're a psychiatrist? Like what's that like?
You faded out a bit, so I didn't hear the full question. Could you please repeat that?
Sure. Okay. I said that I know that you've gone to several countries to do medical clinics, and I was just asking. I was just wondering how are you received as a psychiatrist in those different countries? How are you?
Good question.
All right.
Well, I'll say first of all, I'm received very well as a person. I enjoy the work that I do, and I provide medical care. But when there's an opportunity to provide psychiatric care or to listen to someone or to make a psychiatric diagnosis, I take full advantage of it.
Okay.
And interestingly, people receive it pretty well.
Okay.
I'm happy to say they've received it pretty well.
All right.
Yeah.
Okay.
I've met people I met a kid in the Philippines who clearly had attention deficit hyperactivity disorder.
Mm.
I've met depressed people in Malawi, Africa.
Okay.
I've met people who have mental illness, let's say in Lebanon, and they had already started treatment with a psychiatrist over there.
Okay.
So I think that, to answer the question, they've received me pretty well, and they want the care. They do want the care, because the bottom line is people don't like suffering. And to suffer emotionally and psychologically, I think it's one of the worst sufferings that can take place. When you have what they call psychic pain, and there's no relief. You can't sleep, you can't eat, you're just not well.
Okay.
And these things can, push people to suicide. Which is, a total loss of life. So,
okay.
So yes, it's received well.
Okay. Have you seen in terms of like with the whole quarantine, the coronavirus situation? Have you been seeing a lot of potential suicide cases like in your office, like an increase?
I don't know if it's an increase. I would have to go into statistics for that. But what I have seen personally is that people who are anxious have become more anxious.
All right.
People who are depressed have become more depressed. People who are paranoid have become even more so. And so there's a need for treatment. Because you see, Tommy, we're social creatures.
Right.
That's the way we're made. And so now that we have this shelter in place, we have people who have not seen family members face to face, have not received an embrace because of that shelter in place. And all of that has an effect upon us. And I was telling my group the other day, the folks I work with, that I treat a psychotic individual. He has schizophrenia, and I listen to his ideas of paranoia, whenever he comes to my office. But recently, I saw a bit of a breakthrough where he slowed down in all that he was saying. He looked at me, and then he looked down on the ground, and he said, "Doc, I'm lonely." Loneliness is real. It hurts the heart, and so this shelter in place can cause loneliness, can cause frustration, can cause anger, fear, a whole bunch of things. So I will say that there's more psychopathology being manifested because of this shelter in place. I know we're trying to save our lives, and it's the best thing in order for us not to have this virus that can potentially kill us. But there is a price that we are paying. There is a psychological and emotional price that we are paying where we're not socializing. And in general, most of us are social creatures.
That's interesting because my son, who is more of an introvert, he wants to go out more, and my daughter, who is more of an extrovert, she wants to stay home more. So
Wow.
it's like it's interesting how, like you said, it's affecting different people. You know.
Mm-hmm.
But listen,
Yeah.
I always thank you for just always making yourself available, man. There's you're definitely a blessing to our community, man, because you provide a wealth of knowledge and your service. You're a very kind person in terms of how you how you operate with people and your patients. And everyone that I've sent to you, they've said, yeah, Dr. Artie is good, man. Like he's a good guy, and you could tell that he cares about you. So I definitely want to thank you, man, for the work that you're doing in our community, and the willingness to educate people and to just help with these the stigmas and the myths that people have in regards to psychiatry. So I really want to thank you for coming today, man, and I really appreciate you. So I don't know if you want to say anything before we close out.
Well, same on this end, Tommy. I appreciate you and the service that you provide to the community. Psychological care, appropriate psychological counseling is not very common to get it from somebody who, from your end, who believes, and so you're doing a mighty service, and people appreciate it. From all that you've sent to me and from those I've sent to you, there is certainly an appreciation of who you are and what you do. So thank you also. And thanks for this opportunity, because it's a service to the community. It's knowledge. And,
yeah,
in the book, I think it's in, is it in Hosea?
Okay.
Where it says, my people are ravaged, or my people die due to a lack of knowledge.
Right.
And so what we're doing is we're trying to provide that knowledge to people so that they can live and have that abundant life, that Christ says, he came to provide.
Right.
Full measure.
Right.
Yeah.
Okay. So listen, man. Thanks again, and hopefully we'll talk soon, and maybe we'll have you on again.
No problem. I'll be more than happy. I'm willing. All right. Take care.
All right,
Thank
man.
you.
Have a good one. Okay.